Welcome to the Dan Stevens Show. Delighted to have Shane Smyth with me today. He is a neurologist. Aren't you, Shane?
Yes, I am.
It's amazing the people that you meet through stand-up comedy. This man is a stand-up comedian and a neurologist. And the first thing he did when he came in here was pick up that Rubik's Cube. And he is thoroughly enjoying it. He nearly has one slice done, as you call it.
Yeah, from what I learned years ago, you like I just learned off the moves. Some people are just, and I just learned off the moves. But yeah, if you conceptualize it with slices, it's much easier. So trying to get the first slice done, and then, as you said, I don't want to do the podcast anymore. Just Rubik's Cube all the way. Yeah. Back to you.
So tell me, Shane, what is how would you describe neurology?
So it's a study of, I suppose, the nervous system. And that would be, there's, broadly speaking, the central nervous system, which is the brain and the spinal cord. And then everything that comes off the spinal cord and even the nerves that feed into the face and the head and everything, that is the peripheral nervous system. And it's about that. And I suppose it's a medical specialty. It's about what can go wrong with it.
Okay.
That's about it.
And how long have you been doing that?
So, let me see, how long have we been doing it? I did residency in the States. I was in Ireland for a few years, working, just doing your kind of basic medical stuff. And then did residency.
So like when you left school, what did you do?
Oh, sorry. So, left school, went into medicine in Galway, which is a 6-year thing. Most medical schools, I think, are still 6 years.
Yeah.
There's sometimes 4 years, particularly if you're a graduate entry, meaning that you've done typically another degree in something, and then you decide you want to do medicine, then you go back in, but you're already a graduate, and you go back and you study medicine. They're often 4 years. I think Limerick is 4 years. There may be some other places that are 4 years,
right?
But generally it's a 6-year thing.
So you studied in Galway.
Are
you from Galway?
Yeah, I kind of claim Mayo in Galway.
Well, how does that work?
Yeah, everyone says, "Oh, the football."
You can't claim both.
Yeah, I do claim both. Yeah, I do.
How?
I do claim both. Well, I. Sorry,
it's like a cat. It's like when you scare a cat. That way. Sorry to anyone that's listening. Shane just did the movement that when you frazzle the cat.
I'm like a frazzled
because
cat.
He twitched the curtain. But it's your first podcast, Shane.
It is. Yeah, I'm sorry.
Yeah. I think you're doing great.
I'm doing okay so far. Okay.
So
what are we talking about?
How can you claim both Galway and Mayo?
Well, we moved as a family to Galway when I was 14. So when you're 14, it's...
From Mayo?
Yeah.
Okay.
Although before that, I was actually born in Tuam, would you believe?
Tuam?
And I moved up to Dublin, to Malahide, the moorings. And I was like, I remember kind of, I think I was 3 when we moved down to Mayo.
Okay.
So I've been all over the place. So, in Mayo, even though I was only like 3 or 4 when I went to primary school there, I think they regard us as outsiders too. So I've never been at home anywhere. Yeah. So then I moved to Galway when I was 14. So when you move somewhere when you're 14, it's still a very formative year. So,
yeah.
So I have friends I was back in Mayo visiting people a few months back. And but my parents live in Galway. So I kind of claim both because I kind of grew up both places. But
let's put it this way. Mm-hmm. If Galway and Mayo were playing in the All-Ireland final.
Mayo. I'd be up for Mayo,
there you go. That says it all.
Yeah, I suppose.
I think that's the real test.
Yeah, and also when we moved in 1989, it was Mayo were in the final that year, so maybe that's particularly why I would. And they lost, of course.
Of course, they never win.
No, sadly. And like I don't really know anything about football, to be honest with you, but I respect it. But yeah, I'd be up for Mayo.
So you studied in Galway.
Yeah.
And then moved to America, did you say?
No, so when you finish medical school, you have to do an intern year, and it's usually, I don't know the way it's set up now, but back then it maybe still be exactly the same. You do 6 months medicine, 6 months surgery. That doesn't mean you're operating surgery year. Yeah. I mean, certainly my surgical intern year, 6 months was just there's a lot of phone calls and writing letters, and there's a load of that in medicine that people don't really appreciate. The admin aspect of it. So I was in Tullamore actually for my surgical 6 months, and then I was in Galway for my medical 6 months. So for medicine, I actually did 2 months of neurology, and then the rest was just other specialties. And then once you finish your intern year, then you typically do senior house officer, SHO.
Right.
That's the hierarchy. So it's a lot of people don't know this. So in hospitals it's intern, then senior house officer, and typically people are senior house officers for
Is
2
this
years.
in a neurology?
No,
department?
just in medicine
In
general.
general.
Yeah,
Okay.
yeah. And you do typically 2 years as a senior house officer. Now you may have gone into surgery already, but you'd be a surgical SHO, senior house officer. And then you typically do. I just went the medical track as neurology. Well, I didn't really know what I wanted to do at the time, but anyway, you do an intern year. Everyone does it, regardless of what you're going to do. And then you do. Typically, then you'll do 2 years as a senior house officer. So you're more senior than an intern. You probably have different responsibilities, and then most people try to get on what's called a specialist registrar scheme, which is you're in dedicated training for whatever specialty you want to do, and you typically go around. I mean, medicine's a very what's the word? Well, you typically travel all over the place.
Right.
Just like you do a year here. You're lucky in some ways if you get to do a year in a single place. Sometimes you're just traveling everywhere. But so then so if let's say you want to do neurology, okay. I didn't do my training in neurology here in Ireland, but typically you do an intern year, you do 2 years as a senior house officer, and then during that time you'll apply for a specialist registrar scheme. It's called a scheme. And then if you get on it, it's gonna be really competitive. Sometimes it's there's loads of places, and sometimes not. And then if you get on the special registrar scheme, then then you'll be in dedicated training for I think 5 years,
Okay.
typically in different hospitals. Typically, then when you're finished, I mean, you could just go straight into, let's say, private practice, I guess, but to work in a public hospital, it's often expected that you'll go off and do subspecialist training. So this is especially of, let's say, neurology, but subspecialty would be things like, let's say, cognitive neurology, where you focus on dementia, or movement disorders, where you focus on things like Parkinson's disease, even though there's many other diseases in that subspecialty. So there's various subspecialties.
Okay.
And you typically do a fellowship. A lot of people travel away to that, like UK or America, sometimes Canada. And then you do probably about a year or two, often 2 years. And then you try to get a permanent job.
Right.
So it's nothing's guaranteed. That was a long-winded answer, wasn't it?
Ah,
Yeah.
it's a long-winded process.
Yeah, I guess so, yeah. Even I don't understand it, but yeah, that's the.
So would it be fair to say that it's a theory? Is there a practical side to what you do, or is it all theory driven? Is it all diagnostics, or is there? You're a doctor, but you don't like when I first heard neurologist. There's a few terms I was like, does that mean you? And I guess people would say this to you. Do you operate on brains?
Yeah,
Do people think that?
All the time.
Yeah,
Like, oh, you're a brain surgeon. I'm like, no, I'm not a brain surgeon. Like, I'd refer to brain surgeons, to neurosurgeons. Even neurosurgeons aren't always brain.
You've referred people for surgery.
Yeah. I mean,
Yeah, that'd be your.
Yeah. Not everyone needs surgery. I mean, like, if you've epilepsy, for instance, the majority of people will be controlled in medication, but there'll be some people who you can't get their seizures under control, and they need a dedicated epilepsy center, and there may still not be anything that they can operate on, but sometimes they have to look and see, okay, if the seizures aren't getting under control, is there some focus in the brain that we can resect, for instance? Or some other, and they have to do really fancy stuff that I have only some knowledge of, to try and identify where the seizures might be coming from, and then is it something that they can safely take out to get better seizure control. But yeah, I mean, you might see someone who comes to you as a neurologist with a seizure, let's say through casualty, and then sadly it might be secondary to a brain tumor, and those patients you'd ask the neurosurgeons to get involved. You'd probably still follow them along for the seizures. But yeah, so
neurosurgeons and neurologists, separate thing.
Absolutely a separate thing. But we'd have overlap, and we would have a lot of mutual patients.
Yeah. So you basically help people as much as you can to the point of surgery.
Depending on the disease. So I mean, most of what I would see doesn't need surgery. Like most epilepsy doesn't need surgery. My particular subspecialty is neuromuscular medicine, which is kind of diseases of the peripheral nerves, which I mentioned, or
as for example,
like neuropathies. Have you heard of those neuropathies? So a neuropathy is really it really means disease of the nerves, I suppose. But your typical neuropathy would be, let's say, you've got some numbness in your toes that's gradually spreading, or burning, or that kind of sensation in your toes, your feet, and it's gradually ascending. And the most common cause of that would probably be diabetes,
Okay.
alcohol maybe as well. But there's a huge list of things. Like a lot of the time they're inherited, not always, but a lot of the time they're genetic, and like they would not need surgery. I can't think of a situation where they typically need surgery, but
Lifestyle change.
so depending a
Yeah.
lot of most medicine in general. I always say this: most ill health is bad luck. It really is. I mean, it's yeah, it's even smoking. I think it's only 20% of smokers get lung cancer. Now it causes of COPD and all this other bad stuff, but
And then even when you say smoking, like, are you smoking 2 a day? Are you smoking 20 a day? Are you smoking 10 a week?
yeah,
There's such a large range of consumption
I
as
think
well.
I think though I'm not. I know respiratory medicine isn't my. I don't know a whole lot about it, but I think that smoking generally. I think the evidence used to be anyway that if you smoke at all, it's bad. Whether it's Silkcut Blue or if it's Marlboro Reds or whatever. I don't know if that's accurate, but that used to be what people would say. So I think smoking generally is bad. But you can not smoke and still get horrible diseases. You can look after yourself perfectly. You can be physically fit and still bad luck. I mean, motor neuron disease, ALS they call it in the States, not a nice disease. And
Who would be a famous example? Is there a famous person that had,
ALS, motor neuron disease.
Yeah.
Lou Gehrig is the famous guy.
Lou Gehrig?
It's called Lou Gehrig's
like
disease.
the poster boy?
Yeah, I think there was even a Simpsons joke where they were like, "Oh, Lou Gehrig
Who is
got."
he?
He was a baseball player.
Okay.
Yeah, and he I think he's baseball. Yeah, and he was. I think the Simpsons joke was Lou Gehrig got Lou Gehrig's disease. What are the chances? Something like that,
Yeah.
Yeah, but I think Stephen Hawking had motor neuron disease actually, as well. Yeah,
Oh,
yeah, I'm
right.
pretty sure there's motor neuron disease.
Yeah, I remember watching the movie about him. The movie was him in his younger years. He was fine.
Yeah, yeah. So it's. I mean, it's. I always think being human is hard enough. Just having a significant medical illness is on top of everything is. It's awful.
Yeah.
But motor neuron disease is. Yeah, it can be particularly grim. Generally speaking, if you've been diagnosed with it, you don't have a lot of time left. You probably have, kind of, I don't know, is it 2 to 5 years? But then there's outliers. You'll see people who sadly go down within months, and then you'll see people who have it for a couple of decades. So
Is that all genetically?
no, there's some genetic component to motor neuron disease, but most of it isn't genetic. So again, it goes back to a lot of it's just bad luck, and yeah, I've just learned there's no point worrying about things because just stuff is going to happen. It's going to happen. Easy for me to say, but
Is there with motor neuron disease? Is there telltale signs? If you catch it early, is there any advantage in that?
No would be the short answer.
It's unstoppable.
Yeah, but no, but I'm not. I should be very up to date on the latest stuff about it. There's certainly stuff going on, and there probably will be a cure in time. But at the moment, it's still. I mean, you can prolong life with good nutrition and all that kind of stuff, and sometimes people with certain respirators essentially you can prolong life, and there's some medications that help a wee bit, but it's still a generally a bad diagnosis to get in terms of longevity.
What would you say is the worst? Say if there was 3 worst diseases that you've had to diagnose in your job, what would they be as a neurologist?
I suppose motor neuron disease probably is the worst.
Number 1.
Sometimes it's there are diseases that have a reputation, and when the patients hear about them and you give them the diagnosis, obviously any diagnosis is a big moment for patients. But like multiple sclerosis, people often hear that and they freak out, which is totally understandable. But it's just radically different to the way it was in terms of what we can do. There's loads of medications now. loads of medications for multiple sclerosis. So if you catch that in time, and multiple sclerosis is basically an inflammatory disorder of the central nervous system,
wow.
which again is the brain and spinal cord. I'll be quizzing you on this later. And so it's basically a spot of inflammation or spots of inflammation that occur in the brain and spinal cord, and then they may come and go, and you may have no symptoms for maybe even years, but they tend to leave little scars. And then you may get a flare up that causes symptoms, and the patient goes to the doctor. Let's say it's they lose vision, which typically does get better, I have to say. But and then you scan the patient, and you can clearly see multiple sclerosis. Sometimes it's not that black and white, but it's usually a straightforward diagnosis.
Yeah.
But usually when you get multiple sclerosis, if you diagnose it now, there are great treatments that can keep patients healthy.
Yeah.
There's not, there's still aggressive multiple sclerosis. Some people, like any disease, there's some stuff that's just kind of, on the milder end, and then there's some patients with aggressive disease. But we now have medication that you can, really, you have the big guns that kind of get under control. Yeah, and then there's other stuff that can be done.
So the name multiple sclerosis, like, does that come from? Was there just one sclerosis and then it turned into multiple? What is a sclerosis?
Yeah, sclerosis. I think it comes from.
Who's quizzing who now?
Yeah, exactly. Yeah. No, I'm leaving. Yeah, there's. I think it comes from post-mortem studies where the actual.
Nice and close there.
Yeah, sorry. Can you hear me?
Yeah,
okay.
Push it back towards you a bit there.
Hello, Wembley. Yeah, and I think it comes from the sclerosis means hardening essentially.
Oh.
So I think the like in the spinal cord areas that would be affected would have been harder to feel.
Yeah.
And multiple in different areas. Yeah.
Right.
So like with one.
Oh, so that's what the scarring is. The process of scarring is sclerosis. Would you say?
Yeah, essentially. Yeah. That sounds about right. Yeah, I think
nailed it.
Okay. Yeah. I should have brought a text.
So is it the build up of them then that causes what are the physical symptoms of multiple sclerosis?
So you may have none. You may have known
when it gets to the point.
So so you may have
what would be your first sign that you have it, like?
Well, it may differ from person to person. Now, sometimes there's a kind of a prodrome, a kind of build up. Some people have kind of aches and pains and that, but just running out there, I mean, everyone gets aches and pains, so it's very easy to start thinking you have stuff.
Yeah.
But one of the commonest things we would see would be a thing called optic neuritis, where the nerve that leaves the eyeball with all the visual information heading towards the brain, that gets inflamed. Okay. And it's basically an immune attack. It's your own immune system attacking the brain and the central nervous system essentially. And so that would be a very common. It could be anything though. You could get someone with, let's say, a numb, weak arm, but it could be optic neuritis would be a common one. So let's say over days their vision just gets kind of blurred and it hurts a little bit to move their eye, and it gets blurred, and then loss of vision. And it can be obviously very frightening, but typically in multiple sclerosis though, that they'll get the vision back fairly well. I mean, very well typically. Usually, often 100%. And often we give them steroids, which are nasty drugs, but we give them a huge dose of steroids, typically into the vein. But you can give very high oral steroids, and then that dampens down the inflammation.
Okay.
But you can't just treat people with steroids long term. You need to get them on what's called disease modifying treatments, which are kind of immune treatments to kind of keep your immune system under wraps, so it's not attacking your brain spinal cord.
All right, that's a fairly comprehensive assessment of
MS,
I'd say.
Maybe.
So would you say that's number 2? Is that like the second?
No, I just kind of mentioned. I think it's just when you tell patients this, they tend to understandably freak out, as anyone would. But it's actually so treatable, generally speaking, these days that it's not the worst. Remote neuron disease is probably the worst. Strokes can be really bad too. I mean, a really bad stroke, and it's not just elderly folk. You can get children can get strokes. All the stroke is I mean, it can be a bleed, but an ischemic stroke is probably most what we'd see, where there's essentially a blockage in an artery. And then you get just like if you cut off the blood circulation to your finger and your finger dies, it's you get a chunk of brain that dies. So strokes can be and they come out of the blue. Obviously, it can be fine one moment and bang, you have a stroke. And if it's bad, it can be just you're it's just devastating. However, stroke as well is if you treat it in time, if you get in on time to the hospital. You get kind of clot busting medication. That doesn't always work, but it can. It can, and even if that doesn't work, well, whether it does or doesn't work, they do scans, and if you can see that there's a big artery that's blocked up in the head, then typically you'll send the patient. You may give them the clot busting medication anyway, but typically then they'll go to a center where the very skilled interventional neuroradiologist will feed a catheter in through the groin, typically, and up to the brain, and pull out a clot. It's brilliant stuff.
Wow.
Yeah.
Yeah, my dad had one 7 or 8 years ago.
He's looking okay out there.
Yeah, we just saw him.
Yeah.
What?
Wheeling out with something there. He's stealing something from a house.
He's bringing stuff up to the skip.
Yeah. Okay. Well, he's looking. I wouldn't have.
I'll tell you, when there's a skip within 1 kilometre of my house and there's a bit of space in it, my dad will find it.
Well, the stroke hasn't stopped him. I'll tell you. Yeah, he's looking
flying.
well. He's looking well.
Yeah. Where did you might or might not know this, but why is it called a stroke?
That's a good question. Why is it called a stroke? I never really thought about it. I'm sure someone knows. I should know. I don't know. It sounds kind of sudden. They're sudden. I think it must be something to do with the suddenness. Cut. Yeah, I don't know. I don't know. Why is Dan called Dan? I don't know. I'm sure someone knows, not me. Stroke. Yeah, good question. But stroke is the preferred term. There's some people say CVA, cerebrovascular accident.
Oh, that's the medical term?
No, that's the term that some non-neurologists use, but neurologists prefer stroke. That's the formal term, stroke. I don't know.
I'm an awful man for the language.
Questioning it's cool. Language. Yeah, no, I like etymology. Is cool too. Yeah. All that stuff.
Good word.
Yeah.
Oh yeah.
What's the etymology about?
The subject, eh?
Yeah. Yeah. I can swear. Can I swear?
Yeah.
Sorry.
Yeah.
I don't swear. I just swear for this podcast.
Well, I'm gonna put it out there. What is does anyone know where the term stroke came from?
I could Google it. I'm sure someone knows. Stroke. It must be something to do with the acuity, the suddenness of it. I'd say. Is it stroke?
That'd be a strike, would it? Like lightning. That'd be more.
Maybe we should call it strike.
Maybe it should be called strikes.
It probably should be called strike. Yeah.
What roughly would you say, from the strokes that you've seen happen, what percentage of them would be lifestyle caused, would you reckon? And what percentage would be bad luck, as you said earlier?
Well, I think even when it's lifestyle, there's always bad luck. That's a big component, I always think, with these things. But yes, I suppose smoking is a big risk factor.
The narrowing of the arteries.
Yeah. So So if you smoke, I mean, whatever about lung cancer and all that stuff, in terms of the arteries, you can clog up your arteries. Like the internal carotid arteries up here, they often will get clogged, and there's a certain percentage beyond which surgeons might go in and scrape all the stuff off, basically.
Yeah.
So smoking is a big thing, and high cholesterol, and that contributes to the plaque, basically, the atherosclerosis plaques and everything. So I think having high cholesterol is often just bad luck as well, and just genetic thing often. But yeah, smoking's a big thing. But then again, sometimes people just get stroke. Well, if someone gets a stroke and there's no clear cause, or there's no clear risk factor, they're healthy otherwise, you really do have to go looking.
Yeah.
Sometimes one of the main things is the cause of stroke is a thing called atrial fibrillation, which is where your the atria, which are the chambers in the heart. There's the ventricles in the atria, where the atria aren't, they're kind of squirming rather than contracting, right?
Okay.
And I always think it's a bit like if you're stirring soup and you don't stir, the soup gets stuck to the bottom, you know what I mean?
Oh, yeah.
So it's
porridge, that happens to me.
Yeah, exactly. Yeah. So I always think it's a little bit like that. So that if it's not pumping right, clots could form.
All right.
And then they can travel up to the brain.
Wow.
So when someone has had a stroke, sometimes it's obvious that they're in this thing called atrial fibrillation, just based on the ECG, the thing they put in your chest, the stickers, looking at your heart. But sometimes you have to go looking for it. You have to wear a monitor, and they look at your heart rhythm over time, and they see, oh, well, he is going into atrial fibrillation. And if that's the case, they'll put you on blood thinners.
Okay.
Yeah.
Wow. Yeah.
You'll be on blood thinners anyway after stroke, typically.
My dad's still on them.
Yeah, but more hardcore blood thinners, I should say, if you've atrial fibrillation. Yeah.
What other medication do you need after having a stroke? Is it just blood thinners mainly? And why aren't we taking them in general? Why can't everybody just take blood thinners all their life and then nobody ever has a stroke?
because I suppose you'd end up with people having unnecessary bleeds. Yeah. So I think, as far as I know, the primary prevention with things like aspirin, I don't think that works. Primary prevention means, you go on something before it happens.
Yeah.
Secondary prevention is, let's say you've had a stroke, they haven't found atrial fibrillation, they haven't found anything that they can really.
What's atrial fibrillation again?
Sorry, that's
in layman's terms.
That's where the chamber of the heart isn't
Oh yeah.
pumping right, and in that situation, if you had a stroke, you should typically go on one of these more hardcore blood thinners. But for otherwise, if it's a stroke and they haven't found atrial fibrillation, there's no other major reason for having a stroke, you'll typically go on aspirin, sometimes some other blood thinners alternatively. But if you have atrial fibrillation, you should go on what are called DOAC, which is direct oral anticoagulants.
Cool.
Yeah.
Let's hope neither of us ever have a strike.
Strike, yeah. I will campaign to get the term changed after I look up why it's called stroke.
Hits you like lightning.
Yeah.
Like a strike.
Yeah.
So, what's your favourite thing about being a neurologist?
It's interesting. The
was there signs before you? What age were you when you knew you wanted to do that?
I was already a doctor. I think I was actually doing a rheumatology job. Rheumatology is kind of
bones.
but joints and bones and that kind of stuff. And I was just doing a 1-year job as a registrar. I remember intern, SHO registrar, and then as consultant. And I just it was kind of because I didn't know anything about neurology, and I kind of thought, this thing is, I want to know more about it, and it seems cool.
Yeah.
And I also wanted to I wanted to go to the States as well, just to go to the States. You like the States too, I think. Florida anyway.
I do.
And so I thought, okay, I'll go to the States and do residency. I didn't really think things through anyway, you know.
When did you go there?
I think 27. I think it was 27 I went there.
And so you were fully qualified and everything.
Yeah, it was a few years. Yeah,
so went over to practice.
Yeah, whenever I did residency, I had to go back to being an intern again.
Why do they call it practice when you've already learned it? Like, you start practicing as a doctor after you've learned, don't you? That doesn't make sense either. What's going on here?
It's all practice, really. It's all practice. It never ends. It never ends. I don't know. Again, I will bring this up in the next committee.
Please do.
Yeah, meeting.
Yeah. You should really learn before you start practicing.
Yeah, or doing podcasts.
Doctors are just practicing.
Yeah, we are. Just non-stop.
The place is called a practice. Like, I don't want you practicing on me.
Yeah, it's non-stop learning. That's the thing. It's non-stop learning. Yeah, I mean, yeah.
I'm going to that practice because I had a strike.
I had a strike, and this guy needs to practice. Yeah.
So, I'm learning that when you hear the term anything with neuro in it, you think of the brain automatically.
Yeah.
But it's everything that connects the brain to the rest of the body, right?
Well, yeah, I mean, the brain is...
the nervous system.
The brain is obviously a big part of it, but it doesn't have to be the brain.
The nervous system is the system of the brain, and the brain is the control area. Is the control box. If you were to compare it to electricity, it's like the fuse board in a house. Would that be right?
Yeah.
And the nerves are the cables that go everywhere.
That sounds right. Although even if you have a really damaged brain, your peripheral nervous system, all the other nerves coming out from the spinal cord going down your arms and everything, they may be perfectly healthy still. So so it's the central nervous system, peripheral nervous system, but you see diseases that will affect both, you know. Next question.
Next question is I had a good one there. Well, go on. Sorry. Yes, let's do that. Sorry, we're gonna take a little moment now. Shane very kindly brought gifts, and I'm gonna just say while I have the chance, will you please follow on Spotify and rate 5 stars, or on Apple, wherever you're listening or watching. On YouTube, please like, subscribe, and share as well. Just want to say thanks.
You don't have to give me 5 stars, but give him 5 stars.
Yeah.
Okay. Right.
So here we go. Some gifts from Shane.
This is optional. This is
wow.
This is a 1970s phone. This was because I saw your desk and I thought maybe this would be good just to have on your desk. However, there's no compulsion to you can throw it away as well.
I absolutely love it.
But also it's a good fidget spinner.
Yeah.
Hello?
Where did this phone live?
So I got that at auction recently, and knowing that I was going to come on this, I said, I'm going to
Amazing.
get this
Oh,
phone for
Shane, that's so
downstairs.
thoughtful.
Oh yeah, no problem.
Thank you so
But
much.
there's no compulsion to use it because it is. I don't even know if it works.
Oh, it's coming in.
It's just
I
for.
love it.
It's just for show. The aesthetics of it.
It's beautiful.
Okay. And
I'll be honest with you, it looks like the kind of phone that someone would call for help while they're in the midst. Now, this is just my brain, the way it works, but like you ring when there's a serial killer about to get into your house.
I thought it was perfect for you.
Yeah, thank you. Yeah, I'd say there's been a few tragedies reported on that phone.
Yeah, God, it would be good to know.
A lot of emergencies, I'd say.
Yeah, it would be good
Or
to
maybe
know.
just some chats. Is it an Irish phone?
I don't know. It was in the auction it said it's from the 70s.
Yeah.
That's all I know. So
And
God,
where was the auction?
you know South Dublin auction. They've an auction every Sunday or something.
Yeah.
Yeah, every Sunday. They've all kinds of stuff.
Phones
So,
tell
yeah.
a story, don't they?
Yeah.
That phone is nearly 60 years old.
Yeah.
50 or 60.
Yeah.
And look at it.
Yeah, it's a pity we can't figure out the.
I hope it looks well on the.
Yeah.
I'm sure it does.
Yeah.
I'm sure it's in the picture. I'll pull it back a bit, make sure it is. But thank you, Shane.
Of course.
That is amazing.
Well, again, there's
Brilliant.
no compulsion. I won't go crazy if I don't see it in your desk again.
No. I think it fits in perfectly.
Okay, good. And then, cause I'm classy, Ferrero
Oh
Rocher.
my God.
Yeah. I was gonna get donuts, but I didn't have time. So Ferrero Rocher.
Shane, you know what?
Yeah.
I can tell that you've watched the podcast and listened to it, and you know me. You must know me well.
Are you into those?
Oh, I love them.
Oh, I didn't know. honestly didn't know.
Forever.
I
Roger.
was gonna get you donuts.
This is
Even better.
amazing.
Let me tell you, the phone costs even less than those. So just be honest.
I'm so happy right now.
Good, yeah, good.
Thank you.
You're welcome to have one. That's the end of the gifts, by the way. I still have the hammer we talked about. which
Oh
is-
yeah.
that's not
By
a
the
gift.
way,
That's
just
not
to
a
let
gift.
you know, tell the viewers and listeners what we're going to be doing with the hammer and what the hammer is, Shane.
Well,
Thank you so much.
Oh,
for
you're
those.
welcome. You're
That's
welcome.
my week sorted anyway.
Yeah, you can even have them now if you want.
5 a day.
Yeah, it's one of your 5 a day.
It's hard to stop once you start eating.
Yeah, absolutely. Yeah, no, they're great.
It's hard to stop once you start eating.
Do you remember that
these.
ad about the?
I'll end up having a strike.
Do you remember the ad with the ambassador? Oh, thank you, or ambassador. You outdone yourself again. Remember that old Ferrero Rocher ad? It was like it was from the 90s. It was so ridiculous because it was kind of like they're at a party and a real soiree and everything's dressed up to the nines and it's like the ambassador or someone comes out with Ferrero Rocher and like, ambassador, you've outdone yourself. Did you ever
Yeah,
see that ad?
no.
Oh, it's so good because it's like, Ferrero Rocher is like, oh my God, caviar or
Oh,
something.
it was always like the
Yeah.
Ferrero Rocher, and it's a
Yeah.
French name, isn't it? So
Yeah.
it's like, oh my
Yeah,
god.
I know. Yeah, only the
Yeah.
best. So yeah, the hammer is a reflex hammer. So I can show you now if you want. If you
Yeah,
want.
let's
You
do
want
it
to-
now.
Okay. So this is just to show you the kind of shite we do as neurologists. Sorry for swearing. So this is here. I also have a tuning fork.
Okay.
Don't worry about that.
Do I need to remove my clothes?
You don't have to. In fact, no. You don't have to use your clothes. We'll just talk about it.
Do I need to remove my t-shirt or pull my sleeves up?
I'll
or
just
anything?
I'll just show you the kind of
So
stuff.
what are we doing here? This is a hammer, is it?
Yeah. So this is when
It doesn't look like a hammer.
yeah. So when
Hold
you're,
it up to the camera there.
and this is
Weird looking hammer.
Yeah, there's various types. You can get. This is
More like a chisel.
yeah. This isn't my favorite type of hammer, but this is a I can't remember the name of this one, but this is yeah. And there's a very sharp end at the end, which I'll tell you about. But so when you're examining patients, because there's medicine generally comes down to the history and examination. History is about the story the patient tells you. I mean, there's an old line of medicine. If you don't know what it is, go back and take a history. I think people often have this idea that it's
Go
all
back
about-
and check the history.
yeah, it's in the
Okay.
story the patient tells you. I mean, it's largely true because the answer is always in the story, really. I think. It's all doing to myself. So because people have this image that it's blood tests and scans are always
Yeah.
going to be the answer, and they can, sure, but it's the story from the patient is paramount.
Okay.
And then so you get the history and then the examination when you examine a patient, So one of the things we will do, and we will check strength and everything, okay? But reflexes are an integral part of the neurological exam. So it's about the shite out of Dan Stevens. I brought this along.
Let's
This is what we
go.
do.
Let's
Okay.
do it.
So the kind of thing. So we would typically do this. So let's say you're lying there, and
We need to. Can we get this on camera now?
Yeah,
Will I
can
put
you
my
see?
arm up?
Well, is the phone in the way? You think?
No, I think we're fine.
No, you keep it.
Okay,
I'll just
this
attack.
is
I'll
good.
just attack you like you're.
Okay, so what should I expect
You
here?
you do nothing. Oh, you'll see. I just hit you basically. So let it go floppy. Let it go floppy, and then I just do this kind of thing. Okay, so that's a reflex. See that one?
Yeah.
Okay, and then we'll do this one. I have nothing here. This is the biceps. You see?
Jeez.
And then we'll do this one. That's the triceps reflex, and then you can vouch that your leg is moving, and then we'll do this kind of thing. You can see a little one there. Okay?
Oh yeah.
And then we do the ankle.
Will it work if I put my leg up there?
Yeah, mine.
Let's try it.
It's possible that your leg will be too
I'm
kind of
wearing Crocs
splintered.
just on it.
Yeah.
That'll be too.
We won't expose your foot if you don't. Actually, a sneaky way of getting the ankle jerk sometimes is just to hit the bottom. So relax it for a second. You can actually do that. Can you feel your ankle contracting? Yeah. But typically you do this. You'd turn to the side like that. And then you do.
I'm getting the cramp.
Oh, I'm sorry. And you typically do this. That's typically how you do it. Okay. Yeah. Can you feel it contracting there?
Oh yeah.
Yes. That's it. And then.
Kind of enjoying that a bit. Is that weird?
Yeah.
You've unlocked something in me, Shane.
But this I won't do this to you. But this is.
No, I do. What?
No, well, I don't know. This
What
hurts. This hurts. So
That's okay. I've been through a lot.
Really?
Yeah.
Well, okay. You'll have to expose the sole of your foot.
Okay.
Are you okay with that?
I showered this morning.
Oh, that's fine. You sure you're ready for this? You want to put it up there, or that's too?
I can do it. Yeah.
Okay. If you want. So okay. So if you really want me to do it, so
explain what we're doing here.
So you typically, when you do the reflexes, you typically check what's called a plantar response.
Okay.
Because that's the plantar surface of the foot, and that's the dorsum of the foot. So you have to give a painful stimulus. I hate to tell you, a noxious stimulus. Okay. So you do this. You sure you want to do this?
So what reaction should we expect here?
So normal reaction would be that the toe goes downwards.
Okay.
Okay.
My toe's a bit stiff now.
And that probably shouldn't matter. But
My foot cramps very easily for some reason.
I'll get a move on. But sometimes, let's say if someone has a stroke, the toe might go up. So if the toe goes up, it's usually an abnormal response. It's called a Babinski response or Babinski sign. Okay, so it's painful. It's meant to be painful. You sure?
Okay.
Okay, so don't move your toe. Don't move your foot. Okay, 1, 2, 3. See?
Ah!
See, it went down. It went down. I don't know if you saw it go down. Yeah, it went down. Went down, everybody.
Mine went down as well.
Yeah, you don't. I won't do that again to you. But
Do you want to?
you're enjoying it,
fine.
are you? Okay, here we go. So if you're lying in bed, I would do this to you if I saw you on the board.
It's not even sore.
Yeah, so it goes down. That goes down. That's normal. That's normal. That's
So I
normal.
have.
Yeah, well, that'd be a normal. I mean, you don't always get it, but in somebody's motor neuron disease and in a stroke, in various things, you get the toe would go up. That's called the.
Okay, so that shows that I'm alright.
Yeah, well, you may not be all right, but that's
Healthy.
that's
I can keep smoking.
That's a normal reflex. So that's the kind of stuff we do. It's pretty physical.
Yeah.
Yeah, it's pretty physical, and you can't. Yeah, I always think being gentle.
I wonder could they see that was the phone in the way.
Yeah.
We'll do it one more time without the phone in the way, just in case. But we'll definitely put that back. That's a brilliant thing for the.
Cool.
We're gonna do this again.
You want to just
I'm gonna watch it this time. I think I was looking at the camera last time.
In the way, shark is in the
No,
way?
I think we're alright.
Okay, so
this is the test to find. So what would be if my toe goes down? What does that mean?
Well, the toe going down is a normal reflex.
And what if my toe went up?
Well, if it truly, sometimes people just withdraw and it's hard to tell, but if it truly goes up in a pathological sense, that would indicate what's called an upper motor neuron thing.
Oh wow!
Not motor neuron disease. There's the upper motor neurons that travel from the brain to the spinal cord, and then the lower motor neurons travel from the spinal cord down to the muscles, essentially.
Okay.
So let's say in a stroke where you've got a problem in the central nervous system, the brain, or maybe a spinal cord problem, the toe might go up. It's just part of the exam that you put everything together when you finish your examination and you try and figure out where the problem is. So multiple sclerosis might.
Does my foot smell okay? It's not reeking, is it?
It smells good actually. Yeah. Okay. All right. So there's here, and you go from here. You go, if that's the foot, you go like this. Okay. And it's meant to hurt. It's meant to be a painful symptom. So here we go. You do this. See?
Oh.
Yeah. And your foot and your toe went down. And your toe went down.
Yeah.
You enjoyed it, did you?
Yes.
Okay.
I didn't. The first time I looked at it.
Yeah.
Oh, thanks, Shane.
Yeah, sure.
Thank you. How much do I owe you?
About 50. But if let's say someone has let's say someone was paraplegic from, let's say, spinal cord injury.
Yeah.
You typically would get the toes would probably both go up. You know.
Wow.
Yeah.
Wait, the what do you mean? Both two toes?
Sorry, I mean both feet would probably,
Okay.
Yeah, both toes would probably go up. And a
Right.
stroke because it's typically one-sided.
So what do you? Is there a name for that? Let's get back on the mics here.
Oh yeah, sure. Sorry.
What do you call that test?
That would be plantar stimulation or checking for a
Cool.
So the toe going up is called the Babinski response.
Yeah.
So that would be Babinski sign, Babinski response. And the normal thing is or there's different ways of phrasing it. You can say an extensor plantar response. Flexor would be normal. If you don't get any response, we tend to just say it's a mute plantar response. Sometimes you don't know if someone's withdrawing their foot.
Yeah.
Sometimes it can be, let's say, even if someone's in a coma and you do it, sometimes if it's very dramatic, the whole leg can go up.
Wow.
Yeah. So it's all about.
So
it's just
let's
partly,
just see. Can we? So the other one, the hammer one. If I rest my arm on the table, can we do that one for the camera as well to show a normal response?
with the arm?
Yeah.
Yeah, sure.
Is it okay if it's resting? Like, because
yeah.
I couldn't really rest it fully.
Yeah, sure.
So
let's see.
let's show a healthy.
We'll give it. Let me see. I usually grab the hand to be honest. I usually check for what's called a Hoffman's reflex there, which is the thumb goes down. Anyway, so then let me just grab this.
So it has to be floating.
Well, yes, but the way I do it, and it's best to hold. Like you might get on the thing, but
I'm just relaxing my arm.
Yeah, it's best to relax because sometimes if you don't, so and it's all about the so there. If you hit the hit that muscle there, and there you go. And actually, it can come out more if you do something called reinforcement. So if on the count of 3 you bite your teeth like that. It'll come out more probably. So on 3.
On 3, bite my teeth.
No, like sorry, doesn't sound right. just go, just bite down when on the count of 3. So
okay.
1, 2, 3. Yeah, see that you can't see it, but this gets more. That gets more dramatic when you do it.
Wow.
And then it's called reinforcement, and this is the biceps reflex. Okay, actually, you can rest your wrist there. So the biceps reflex is that. You don't have to keep bicep, but yeah. So that's I'm putting my thumb there in the biceps tendon. And so I'm hitting my own thumb, but that's,
Look at that.
Yeah, and then the triceps is this one. Yeah. And then we do all these things. Sorry, Dan.
Yeah.
So open your mouth a wee bit. Relax it.
What are you doing?
We'd even do it. I didn't give you any more.
What reflex there?
It's called the jaw jerk. We check for that sometimes.
You can't see with someone with a beard. How do you know if my jaw moved or not?
Yeah. Well, I just assumed you were dead. To be honest.
Would you have to shave someone's beard to check that one?
No, I don't think so.
No.
We don't always check it. Sometimes we check it.
So you did that very suddenly there without any explanation.
Yeah,
just do it again.
I attacked you.
It's very
Just let it go kind of.
It's
loose.
quite intimate.
Yeah, just get a bit loose like that. There you go. Yeah, it's very normal. It's a normal thing.
Jesus.
A normal jaw jerk.
Did you ever miss and hit someone in the tooth?
No, I don't think so. But yeah, no. The neurology exam is my line about it is that it should be more pogues, less dire straits. Meaning that you have to be a bit rough to do it right. In my opinion, because if you're too gentle, you'll miss stuff. You know, you don't want to.
And they'll end up like Shane McGowan.
yeah.
In dire straits.
Yeah.
All right.
So the tuning, if you want to,
very cool. So, what's this one now?
Yeah. So there's various things. This can be used for hearing sometimes, but generally as neurologists we use this for. Well, there's 2 things you can use. You can use it.
Good for noodles or spaghetti.
This? You think so?
Probably what I'd use it for. Anyway.
Yeah, you're right. So it can be used for sensation because it's cold, okay? It's cold. So even the cold, like soft touch.
Let's keep it in the camera range here so people can see.
So if you touch someone like this, I mean that travels in a couple of different, in two different pathways. It's kind of non-specific, but cold and pain travel in the same pathway.
Oh.
And so sometimes I will just do this to check sensation, okay? But then for a different type of sensation, we do this. We hit it and you feel the vibration?
Yeah.
Okay, so we do that, let's say on the toe. Let's say neuropathies I was talking about. Let's say you bad diabetes and your feet are numb or something. We'll sometimes do that to let's say that was the big toe, to see how long they feel the sensation for. They may not feel it at all. And then we see if they, let's say, okay, I can't feel anymore, but it's still buzzing away. It can indicate there's decreased sensation. Okay. So it's all about, these are individual little parts of the exam. It's all about putting it together, and then of course in the context of the story, the history from the patient. That's when you kind of put it all together.
Yeah.
But sometimes we're clueless. At the end of the day, you do it all. You're like, I don't know, just get the scan and we'll see what happens, because you don't always. You can't always make sense.
So that can basically these exams. Is that it now? Is that all the exams?
Yeah, I mean, I can keep battering if you want, but I won't.
No, that was great.
This was I don't.
So how am I looking, reflex wise?
Normal. Yeah. You're looking fine.
So what would be, say when you're doing them tests, what would be a result? Put the phone back in there.
Oh,
now.
sorry.
Oh yeah. I will put it back there in its new home.
I forgot what it looks like actually. Let me see.
It's absolutely lovely.
Oh, I'm glad you like it.
Oh, it's lovely.
Cool.
Brilliant.
It's a good fidget spinner.
I think it's great.
Yeah, cool.
Yeah.
And you can pretend you're calling people.
It's good for my anxiety.
I like the sound of it when you do
I know,
that.
it's really cool.
Yeah.
All right, we have a
Probably
caller.
works. I don't even know.
Say it does.
Yeah.
But yeah, great. What would be? Say you've performed those tests on someone. What would be an alarming result? Like, what would you? What would have happened there? To like, at what point would you do those tests on someone? What would you be suspecting that? There's something gone awry with their nervous system and there's no reflexes? Is that what you're looking for?
Well, it depends. Yeah, so sometimes someone could have something significant and your examination is still normal. You know, a normal exam doesn't necessarily mean you don't have something.
Yeah.
But let's say...
Process of elimination?
Yeah, a lot of times it is. But let's say it's... so there's a condition we sometimes see called Guillain-Barré syndrome. Okay, it's where it usually comes on over days and it can be very intense. Where people will basically get paralyzed over days, typically. And again, it's an immune attack on the peripheral nervous system.
Right.
Okay, so not the brain or spinal cord, but with some exceptions, but the peripheral nervous system. And we see it probably every few months or more. Sometimes you'll see it. So in Guillain-Barré syndrome, typically all those reflexes, I mean, some people don't have very robust reflexes anyway, and some people have fairly brisk reflexes.
Yeah.
Okay, but
where would you say mine are there?
I'd say yours are normal.
Average.
Yeah, yours are normal. And again, yeah, and it's not that kind of reflex. But it's there is actually a thing called hyperplexia in neurology, where if you do something like that, people just yeah.
When I get a fright or when I get, what should be a jump scare or someone scares me on purpose from behind, which, by the way, I don't agree with.
Yeah.
I don't think people should do that to each other.
I agree.
Because you never know what could happen.
Yeah.
But I don't get any external movement. It just, the fright registers in my head, but I just kind of don't react at all.
That might be a good thing. I don't know if that's probably not pathological, I'd say.
What would that be?
Do you think the fact that you don't?
Sometimes I'd just walk into my family home, and if my sister or my mum is there, I'll just open the door. I'll walk in, and they'll be like, like a massive reaction like that.
Yeah.
But for me, same thing happens to me, or someone walks up behind me, or even grabs me by the shoulders, and I can't see them coming, and they're like, I get nothing. I do get a sort of a small feeling inside, but other than that, I don't get anything.
I don't
get frights, basically.
It's interesting. I don't think that's pathological. I mean,
when you say pathological,
as in, I don't think it indicates any particular condition or it's abnormal. I mean, the thing about normal is there's a huge spectrum of what's normal, so that is probably perfectly normal. Yeah. It may not be, but I can't think of any particular condition that might indicate. Okay. But there are some conditions where you get, it's called hyperplexia, where you get an abnormal startle response. And even if someone's in a coma, sometimes if you do this kind of thing, or you tap them with reflex hammer, their whole body goes like this. Yeah, it's and there's some rare conditions as well where you can get that. Hyperplexia. Right. But I think you're normal. As normal as Dan can be.
Yeah. Because I've never, I remember even, I think when the first of the jump scare movies for me was like Scream. Remember that?
Oh yeah, good movie.
And a scary looking bastard as well.
Yeah, that was a good movie, wasn't it?
That used to get me like.
A friend of mine walked out. I saw it in the cinema. A friend of mine walked out.
The first Scream.
Yeah. A really good movie.
Yeah. I mean, I'm trying to think back to whether I got physical symptoms of fright then. What is a fright? What is the purpose of a fright, of getting a frightened response? Is it like to wake you up? I don't
must
know.
be, yeah.
I'm asking very awkward questions
No,
here.
no, no. It's. I'm sure it's an evolutionary thing that just to suddenly be prepared. I presume. And I think some people have a more calm temperament. Some people are a little bit more wired. And again,
Yeah.
probably all within normal. And I guess if you're a little bit more anxious as a person, you're probably more likely to get
I was thinking that it might be related to being in the fight or flight state.
yeah,
That like, if you're in the fight or flight state, or maybe just in the fight state, that's when you're in the state where you get a fright, where you're ready to like
yeah,
react.
yeah.
But
You might just be very calm.
I think that may be what it is.
That's a good way to be. I think.
But then if it's an actual attack, or somebody really got, maybe it's not a good, or maybe you're just ready to go. I don't know. Yeah, it's an interesting one.
Yeah.
So yeah, we've covered. So to summarize, the main illnesses that you would diagnose and deal with would be, what was the first one? We had MS and
Motor neuron disease.
motor neuron disease,
Stroke.
strokes,
Yeah. Neuropathies.
neuropathies.
Yeah.
What are neuropathies again?
They'd be again. This is very like even that condition I mentioned, Guillain-Barré syndrome, where people get paralyzed.
Yeah, it's not like a face droop.
You can get facial
Yeah.
involvement with that, but it's often just the limbs.
Right.
But neuropathies, the most common neuropathy would be a slowly evolving, smoldering one over many months and years. Diabetes would be a common cause.
Yeah.
But migraine is actually one of the most common neurological disorders. Yeah, so migraine's a big part of neurology as well.
And are migraines more, what's the word? Environmental or I guess genetic? What would be the
Yeah, there isn't like a migraine gene. There's some rare exceptions where but generally speaking there isn't a migraine gene, but it does tend to cluster a wee bit. If there's a family history of it, you probably are more likely to get it. And again, it can vary from just getting an odd headache to having just being plagued by them all the time.
And what kind of advice, or I'm not looking for advice, but I mean what would you say is the best way to remedy a migraine, or is there prevention for migraines?
Yeah, there are, and there's some really good new drugs that have come out in the last couple of years
For migraine prevention.
For migraine prevention and treatment. So if you get a head, I never knew I had migraine until I did neurology. I thought, I just get regular headaches. There's really no such thing as regular headaches. In fact, when you see someone in clinic and you're trying to see if they get migraines, we often ask about hangover headaches, do they get stress headaches or hunger headaches? Because all that is probably just all migraine. Because some people if they get a hangover, it's their stomach. But if you really get a bad headache, that may indicate that you're prone to migraines.
But what if you don't get them any other time, just with a hangover?
Yeah, I would probably view that they're just they're migraines. It's very convenient to just label it as migraines, but yeah. If you get a headache, let's say I had a headache today.
But if you don't drink, then you don't get the migraine.
Well, yeah. I mean, if that's what's triggering your migraines, then I guess the best thing is to do is not.
So you're saying the migraine's like laying in wait for you to drink, and then it's like.
Well, in some people, yeah, it might.
Good morning.
It might be, but there's some people obviously who. So this is like I had a headache today, which wouldn't tick all the boxes for migraine. But being a neurologist, I know it's probably just a low grade migraine. And I took paracetamol, did the job. So if you get a headache, let's say once every couple of weeks, response paracetamol, you don't have to get any more fancy than that. But if you're having headaches that are 2 or 3 days a week, and it's enough to be annoying you or affecting your lifestyle, then you might be someone who needs to go on prevention. Yeah, and there's medications you can take every day to help prevent them.
Is there natural ways?
Yeah,
without medication to prevent them.
Well, yeah, I mean, not going crazy on caffeine, having good sleep.
So the stuff that are you saying basically migraine is like a condition, and certain things trigger it, like alcohol can trigger it, caffeine can trigger it.
Yeah, lack of sleep
can trigger it.
Yeah.
So a migraine is showing itself through certain activities.
Yeah,
but it's always there.
Yeah, sometimes, but sometimes they just come out of the blue, and the patients have very little control. You know, it can just be random.
Yeah.
Yeah, so it can be, again, it's like
But
any.
that migraine is the same migraine that is there for the hangover. It's like
I would view
trying
it
to
as
figure out what
such.
a migraine is. I've never thought about that word
Well,
in
if
that sense of. I just always thought migraine is a headache, but it's actually a condition.
yeah, it's really a syndrome, and you can even get migraine without the headache. You can even just some people get a lot of dizziness and vertigo,
Right.
and like motion sickness is another thing we often ask about. If someone's prone to motion sickness, that to a neurologist might say, okay, well that puts the headaches that they're getting really in a migraine is they're probably a migraine type
Oh,
headache,
right.
you know. So yeah, and it's like anything. Like if you get mild ones, it's probably no big deal. But and often they just come out of the blue, and people are plagued by them. But
Yeah.
there's some really good. So for anyone out there, if you're getting regular headaches to the point that it's bothering you, then you might just need to find the right medication to take regularly to help prevent them. And as I say, there's some even better medications that have come out very recently that are very effective or
Right.
can be very effective. Um,
And
but the
on
lights,
the non. Sorry, go ahead.
I was just gonna say the lifestyle measures. Let's say
That's what. Yeah, I was
yeah,
gonna ask.
yeah, that can help and it can cut down, but for a lot of people that's not enough. That's not enough. You know, you can look after yourself. You know, regular meals is another thing. If you've got big fasting, if you don't eat for hours and hours, that could possibly bring on a headache if you're predisposed to migraine. But the lifestyle measures may only get you so far.
Right.
So a lot of people, despite those things, still need to go on medication.
Mm-hmm.
And yeah, it's so migraine's a big part of neurology as well, actually.
Migraine. Right.
Yeah, yeah. And sometimes even the patients coming in to hospital through casualty, with headaches, they're nearly all migraine.
Right.
You see some serious stuff causing. I mean, not that migraine isn't serious, but some dangerous diseases causing headaches. Sure, that might make you come in through casualty, but by and large, they're migraine.
Wow.
They're probably the majority of the headaches that even come in through hospital and have to be admitted and all that.
Yeah. So if anyone's been suffering with migraines for a long time, there's new medication out now.
Just call the phone.
Yeah.
Yeah.
Call the phone. Can you name this medication? What's it called? It would be, I guess, prescribed.
The new medication.
Yeah.
Oh boy. They are called
Nurofen. Is it?
No. So there's stuff that you. There's
Terrible joke.
No.
Not Nurofen.
I'm
Nurofen.
trying to remember the names of the new ones.
But anyway, if they go to their doctor and ask for the latest, up to date.
I wouldn't go for the latest stuff because people often want to go for the latest new stuff. But sometimes the simpler, older drugs are fine.
For migraine.
Yeah. Like there's a drug called amitriptyline. I don't know if you heard of that.
Okay.
Some people hate it. Some people it just doesn't agree with them. But it's an old antidepressant, which usually freaks people out. But in low doses, tiny doses, it's not prescribed for depression anymore, really. But in tiny doses, in the right person, it can help a lot.
Yeah.
Sometimes like anything, it just doesn't work in some people. But in people who are failing the first line kind of drugs, they now have these other drugs. Some of them are into the vein, and
Yeah.
yeah. So
Here's one for you. Can you do your best to describe the neurological process of a hangover?
oh boy. You see, just being a neurologist
nice
being a neurologist with migraine, I just view it all as migraine.
Okay.
I don't think it's just dehydration, even though that might be some of it.
Is it true that the brain swells in the head and pushes against your skull?
I doubt to any huge degree because true brain swelling is you'd see at the odd time and it's usually a bigger deal.
Okay.
Because if you scan someone with a bad hangover or migraine, like an MRI scan, it'll be normal. Nearly always. I mean, sometimes you see some non-specific stuff with an MRI scan. That's another thing with scans. People just think that those scans are. I get really bad headaches. I need a scan, and we usually get them. Sometimes it's just to reassure the patient. But then sometimes you see non-specific stuff like sometimes you get little dots in the white matter in the brain associated with migraine, and they're nothing to worry about really. But sometimes scans uncover stuff that create a lot more anxiety, and then your doctor's like, maybe we'll do a spinal tap to see, and it just becomes a one thing after another. So there's a lot to be said sometimes for staying away from doctors.
Right.
Yeah, I think so. So scans can sometimes. I mean, Yeah, of course they're helpful, but
Would it be true? I think that doctors always look at, or not predict, but they will prepare for the worst case scenario,
yeah, I
so that
suppose
they
so.
can't be held accountable if they don't find that.
Yeah, no, there's a lot of fear in medicine.
And that's
Yeah.
without any consideration for the stress and anxiety that might cause the patient.
Yeah, there's definitely a fear in medicine that of yeah, getting sued. Sure, sure. Yeah, you know, like, oh, if I don't do a scan and they have something
Yeah,
ultimately, because I mean, you may see a patient, you think to yourself, they don't need a scan, but you know, there's a small percentage that they have something up there that may be unrelated,
yeah,
and if you don't do it, yeah, you're going to get in trouble. There's a lot of, yeah, there's inevitably a lot of fear. I may be exaggerating, but there's a fear in practicing medicine that just exists because, you know, people don't want to get in trouble.
yeah.
Yeah,
No, that makes sense. Yeah,
yeah,
and there's not really any solution for that, is there? Like, doctors have to look at the worst case scenario and kind of um look at every possibility.
yeah,
And unfortunately, it is going to be to the
yeah,
anxiety of the
yeah,
patient.
yeah. Sometimes you pick up aneurysms, for instance. Aneurysms, I think that's about, is it
What are
3%?
they?
So a little, so it's an abnormal kind of dilation, like a blood vessel is a normal kind of swelling of the wall. Not swelling isn't the right term. It's just kind of wider or loosened,
Oh yeah,
and
I guess like a pupil dilates, doesn't it? Gets
yeah,
bigger.
exactly. So
So it'd be like that in the.
yeah, so it's if the blood vessel is a tube, then just a little bit that's
Oh,
abnormally
kind of
wide.
opens up a bit more.
Yeah, and you know they can rupture, and if you've a bleed from them, you know you may not even make it into hospital. You may of course make it into hospital, but if you find an aneurysm, a lot of people are like, oh my god, I've got an aneurysm, and then they're constantly dwelling on it. You know, as I suppose would be natural, but um, aneurysms, you know, the chance of rupture actually is very low. They
Yeah,
have to look at certain things, you know, is it in the front of the brain, the back of the brain,
yeah.
how big it is, you know, there's other
Mm.
characteristics about it. And that'd be an example of if we pick up aneurysms, we'd often get neurosurgery to follow them
Yeah,
because they'd be the experts on that. Yeah.
yeah. I guess it sounds like we've gone through a pretty comprehensive
You're practically qualified now.
thing on. Yeah,
Yeah.
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 Thank you.
Yeah.
I can
No
test
problem.
people now just with a regular hammer.
I should have brought a hammer
So
for
can
you.
people get them hammers online?
I think so, yeah. I think anyone can
So
get
you can
them, yeah.
just check your own reflexes,
You can
like,
get all the stuff
basically,
online.
can you?
Yeah, you can. Yeah, yeah.
It's all
I think so,
accessible.
but it's yeah, but I mean you can't really. I mean this doesn't really mean anything in isolation. You
Yeah.
know, it's all about the context.
Yeah.
So if someone says I have a weak arm.
Context or the content? Bit of both. What?
A bit of both. Yeah, a bit of both.
Yeah.
So it's all about the yeah. So if someone's weak,
Yeah.
if someone's a weak arm, then the reflexes show matter. Where if someone's otherwise fine, no symptoms, what you find in examination may be absolutely irrelevant. You know what I mean?
Oh, that's cool. We'll go with. I'd like to ask you. So, like, I guess a neurologist's advice for people. We'll say three ways to kind of keep your neuro pathways healthy. Three things to do in day-to-day life that you would say as a doctor.
I would say
uh,
number one, don't worry. There's only so much you can do. Just generally about health, you know.
Yeah.
But it's the common stuff, really. You know, exercise, all the stuff that certainly I should do and I don't. You know, be moderate. If you're going to drink, be moderate. Don't smoke. Exercise. All the common stuff is
Yeah.
good for you and is good for your overall neurological and brain health. Yeah.
Is there a certain drink you'd recommend if people are going to drink that's healthier than like an alcoholic? Like,
No.
no.
No, I don't think so. It's all
Guinness has iron, no?
yeah, I think it does. But they used to say that they keep changing what's healthy with alcohol. I think now the concept is that no alcohol is healthy.
Yeah.
There used to be because
Remember pregnant women used to drink Guinness in Ireland?
yeah. That's right.
And we turned out fine.
Yeah, we did, didn't we? You did definitely.
I think we both are alright.
Thanks.
Between the two of us.
Yeah, we managed.
Plenty of water. Do you think water is overrated?
No, water's good. Water's good. I mean, some people, you know, are prone to fainting. And if it's just simple, yeah,
Where's that come from?
yeah, it is. As in, what I'm saying is, if somebody's just prone
Into
to,
water, they faint by the river, and then
yeah, well, if you're prone to faint, like a lot of people are, yeah, prone to faint. Sometimes sometimes as a neurologist, actually, one of the commonest things we get asked is, someone's collapsed and they may even have had a few little shaking out of their limbs, and is it a seizure? You can sometimes faint and get a little bit of a seizure with it. It's called convulsive syncope. Syncope is a fancy term for a faint, and convulsive means a convulsion.
Yeah.
So, but if you're prone to those, then increasing your water intake to 2 liters a day or higher,
All right.
and sometimes increasing your salt intake is important. So I think generally, though, what is it? I think maybe 2 liters a day of water is recommended. I think.
Yeah.
So yeah, it's good to drink a bit of water. Not go crazy with water. Some people get water, like, drink way too much.
Drown.
Yeah, they can drink. I mean, there's a thing called psychogenic polydipsia, where you just drink
Literally
water.
drown, don't they?
Well, yeah, you drink so much water that it dilutes your blood, your sodium concentration is lower, and then that can actually cause, I guess, brain swelling sometimes. Yeah.
There's one thing one more thing actually I want to talk about, and this is, I think, embedded in a lot of lifestyle advice on stuff in the podcast and YouTube world and stuff, and it's about the vagus nerve.
Okay.
And I actually got pretty curious about the vagus nerve myself and the importance of it. Things like deep breathing and ice baths and cold water therapy and stuff are said to be good for the vagus nerve. Like, how important would you say the vagus nerve is, and what is it exactly?
Well, it's a nerve that comes from the lower part of the brain, and it's
so it comes like from the back.
Yeah, from the medulla, which is, the you got the brain stem, which is kind of like a plant, kind of. You got the brain stem. Brain stem is midbrain, pons, medulla, or medulla, some people say, and that's where the vagus nerve starts in the medulla, and they travel down alongside the carotid arteries, and it generally is a kind of chill out. It's not involved in the flight or fight thing. It would lower your heart rate.
It's just like the chill one.
Yeah, it's the chill one. Yeah,
the vagus nerve is like, all right.
Yeah, so the autonomic nervous system.
Let's all
relax. The autonomic nervous system is the nervous system that's kind of subconscious processes. If it looks after your breathing and your heart rate and all the stuff you don't have to think about, sweating, and the vagus nerve would slow down the heart rate and the strength of the contractions, of the heart. So I think just generally just being more chilled out is probably good for you. Meditation is probably good for you. I don't think there's probably a lot of junk online. I don't think I would really get into focusing on your vagus nerve per se, but just generally being less anxious is good for you.
Yeah.
In epilepsy, sometimes they implant what's called a vagus nerve stimulator alongside the vagus nerve in the neck, and so if someone's having seizures, sometimes stimulating that nerve with this vagus nerve stimulator can also reduce seizures in some people.
Yeah.
I don't do it, but the specialist centers might do that.
Is it possible to have an overactive vagus nerve? I think I might have that. I'm a bit too relaxed, I think, sometimes.
I think it's a good
like
way
that's
to
ruined
be.
relationships for me.
Really?
Being too relaxed, yeah.
Really? I think
Just
it's a
don't
good way
care.
to. That's a good way to be, I think.
Yeah.
Better than being
yeah, and I'd be very sensitive to other people's anxiety. Like, I can really feel it. I don't know. I think, but which is a nice thing. It's good to acknowledge other, but I don't like being around people that are anxious or that are worrying about stuff all the time. Because I can really feel it. I think would that be like a sensitive vagus nerve?
No, I'd say that's probably more a psychological thing. Not meaning you're nuts or anything. I just mean it's probably more, or just maybe whatever the way your brain is developed, that you're just more chilled out. I'd say more than the vagus nerve itself, So,
but my vagus nerve would be happy with me. It'd be like, yeah, we like that.
Yeah. The vagus nerve, Dan is cool.
Yeah. I enjoy living in Dan.
Yeah. Yeah, exactly. That's exactly it.
I like to look after my vagus nerve.
Yeah, you should.
And he looks after me.
Yeah, exactly. It's You're friends.
I'd say he hates being named after Las Vegas, though.
Spelled differently, though. It's Vagus. But you heard it here first.
That's how you cut out the spread of misinformation.
Yeah.
right there.
Yeah, exactly.
Nip it in the bud.
Yeah. It's not VEGAS.
Yeah. All right. Is there anything else you'd like to share? I mean, just to add, Shane Smyth is a brilliant stand-up comedian as well, and we haven't really talked about that. But check him out online.
I keep my online presence low.
Yeah.
That's my own undoing. Yeah.
But you're regularly in the clubs around Dublin.
Yeah, ish. Yeah.
Well, you're in our club in Sunday Heroes.
Yeah. At the end of the month, look forward to that. Yeah.
It's brilliant. I did a gig with him the other night in Enniscorthy. Absolutely fantastic. I think the gig peaked when you were on. They loved you. You're brilliant, and in a tough room as well.
Oh, thank you.
You know, when you're in the corner of a pub and it's like the pub is adapting to the comedy rather than it being in its own room. But you really had them. It was great.
I was helped by the crowd, I have to say, but thank you.
Yeah. What else is there? Anything else you'd like to share before we go about that you'd like the people to know, or any have you had much misunderstanding about yourself as a neurologist?
I guess sometimes people think I'm a psychiatrist or a brain surgeon, which I'm not. I just don't worry is what I'd say to people. People were like, people often get little twitches and things and start freaking out about that. I mean, bad stuff can happen, but God, you can just spend your life worrying about stuff.
Keep the cortisol low.
Yeah.
The stress hormone is cortisol. I know that much.
Yeah.
And we like to keep that down.
Yeah. Not getting worked up is very good.
Would you say, in conclusion, that sickness feeds off anxiety and stress?
Yeah, stress is an awful thing. Thing. Yeah.
So chill out, everybody.
Chill out.
That is the advice from our new resident doctor, Shane Smyth, of the podcast.
Yes.
And I'd love to have you back.
Okay, I'll come back.
I
won't bring another phone.
I'll compile some more medical questions. I actually, just to let you know, I had this list of questions written for Shane, and
I shot them all down.
He just said, no, I'm not. That's nothing to do with what I do. And he was right. After talking to you now, all of these questions are completely shit. So I'm glad I didn't ask them.
Well, they were more kind of, I suppose, popular psychology things.
Yeah, I'm just fine. I love a bit of psychology.
It's cool stuff.
Like one of them was Krang your favourite character in Teenage Mutant Hero Turtles? Do you remember him? It was a brain in the little jar.
No, wasn't it? Yeah, wasn't there an alligator or something in the sewers as well?
Well, there was Splinter.
That's good. Yeah, I never really got into them.
Yeah.
Yeah, I respect. I know people my wife is huge into. She loves them.
Yeah, I just thought in my head I was like, what if I had this fantasy in my head of what if Shane got into neuroscience because of Krang, but. No,
it's hard to disappoint you. No, it wasn't that. No, nothing against the turtles.
Who's the? See, this is stupid questions. They're so.
No such thing as stupid questions.
There is. Who's the brainiest person in the world?
Not me. I'll tell you that much. That's a big thing. I'll tell you. People have this notion that doctors are smart. You don't. I'm not. I'm of average intelligence. I'm not just saying that. You just have to read. All you have to do is just read
and work hard.
Yeah, I guess so.
Stick with it.
Yeah, and be enthusiastic about it. But I'm no smarter.
And it's basically. Another thing about, like we said earlier, about a neurologist and neuroscience is a different thing.
Well, I would know neuroscience, just that neuroscientists.
Did I say that by accident during the podcast, by the way?
I don't think so.
Did I say neurologist?
If you did, no. I mean, neuroscience might imply that you may not necessarily be a doctor as a neurologist. You're a medical doctor who's doing neurology. Yeah.
So it's.
Yeah. But I would know neuroscience, but maybe not to the degree that a true neuroscientist would know it. You know, the at a molecular level of the brain. Yeah. I know some of that stuff, but I wouldn't be, I'd be a little different, I suppose.
All right. Here's another couple of what does scrolling do to your brain?
I don't know. Someone probably knows, but I don't.
Yeah, it's not your. See, that's what I'm saying.
I do think though that people think
this is like when you try new jokes out, and the audience is like, no, and then they're like, yeah, they're new jokes anyway.
Yeah.
But yeah, that's a psychology thing.
I think so.
is,
Yeah,
yeah.
yeah. Or I mean, there could probably some neuroscience I mean, it may affect the brain in ways
Yeah.
that I don't know. But I think if you're prone to scrolling everything, it doesn't mean that you've got ADHD, for instance. In the States, I think the neurologists would see a lot of ADHD, but over here, it's typically not neurologists.
Yeah. Um, I enjoy a bit of scrolling. I
Oh
think
yeah, me
feeling
too.
guilty about scrolling is something that's a bit of an epidemic in itself.
Yeah,
Just take a bit of time and enjoy fucking scrolling. Like,
yeah, yeah.
so what if you enjoy Instagram?
Yeah. Oh, I've spent
But
way
yeah,
too
why is it
long.
bad?
Yeah,
You enjoy it.
yeah.
What else
See
are you
some good
gonna do?
stuff.
Sit there looking at the fucking wall?
Yeah, or reading a book.
Yeah, fuck that.
Yeah.
Obviously in you happy saying that. Obviously in what do you call it? What's the word? In the right amount, like
Yes, moderation.
in moderation. That's the
Moderation.
one.
Yeah, yeah.
It's a bad sign that I don't even know that word.
You don't need to.
Moderation.
You don't need to.
Um, strangest fact about brains. See, I just thought it was all brain, but it's not. It's the whole system.
What is the strangest thing about? Yeah. Well, there's a lot I could talk about, but I won't. But seizures are very interesting, and the some seizures, what they can do. Like, yeah, I mean, people think seizures, just like a fit or a convulsion,
Yeah.
but sometimes they're crazy. Sometimes there was a case report I remember reading about a fella who he had a seizure, and his seizure was that he heard Another Brick in the Wall by Pink Floyd. You know that song?
Yeah.
Yeah, so that was his seizure. And when he got scanned, it was a blood vessel abnormality that was causing his brain in that area to make him hear that. I know I'm going off on this tangent. And there was another case report I read.
So what was he just hearing it, and then he was like, "All in all, you're just another."
Well, yeah, he would hear it. He would, yeah, I think so. It's yeah, his brain was, and so you can even get reflex epilepsy, where a certain stimulus, very rare, but a certain stimulus will cause a seizure. Like there's
Yeah.
even telephone seizures where people on the phone, that being on a phone will trigger a seizure. And there's even one case was, yeah, that's when I got it. One
careful.
case was a particular person calling on the phone.
That's where you got
Yeah,
it.
that's where I got it.
Ring, 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 ring. Seize your phone. Bloop, bloop, bloop. Instead of
Yeah.
banana phone.
So that's interesting about the brain. So
Seizures.
seizures can be very interesting. Yeah. Dostoevsky, the writer, I've only read him once, but he one of his books he talks about a seizure, and I think it's felt that he's talking about his own epilepsy. And I wish I had the quote, but he basically said it was an ecstatic seizure. He felt like he was seeing God or something. And he said something like, I would trade all my days just for those moments of bliss. So very, very rarely. I mean, seizures are generally not like that, but
Yeah.
you can get fascinating stuff. Not that anyone should have seizures, that we want anyone to have seizures, but the brain is a crazy place, and you can get crazy. I mean, I read a case report a few years back of someone who had been visited by her guardian angel for years and years, and just assumed it was her guardian angel, but it was a seizure ultimately that she'd been having. And she was in her room, she would see, and she drew it. It looked like a really scary looking guardian angel, but she was assuming this was her guardian angel. But
And then, so that's what she's thinking about while she's having a seizure.
Which may not even. So seizures don't always have to be convulsions. They can even just be smells.
Oh, right.
It's said that George Gershwin, the composer, George Gershwin, is I think it's the early part of the 20th century, and Rhapsody in Blue is a good tune. But he it said he had his whole New York apartment ripped up looking for the source of a smell, and it was just he had a brain tumor causing what are called olfactory hallucinations.
Oh, right.
They were seizures, but basically wasn't his nose. It was the brain was sparking away in the wrong place, causing smells abnormal. He was perceiving abnormal.
That's amazing.
Smells. Yeah.
I've had memory from smell. You have memories that will create a vision of the past, i.e. a memory. But that's not a seizure, is it?
No, I was told that's something to do with evolution and something to do with food and knowing where to go hunting.
Yeah.
Something like that. I told there's some evolutionary reason for that, but no, that's different. Deja vu. Have you had deja vu?
Yeah.
Yeah. So and it's always fascinating when it happens, but that can sometimes be a seizure too.
Oh.
I met a patient once who had. I saw her, I think, in her 20s. She had a generalized convulsion, but she'd had a lot of deja vu for years, and she just assumed she was psychic.
Yeah. Right.
Yeah. Because when you have these things from a young age, you don't think about it. So there's a lot of interest, a lot of tragedy in neurology, of course, but a lot of The brain is very interesting.
I think in this area, in the wider Blanchardstown area, a seizure would usually be defined as when a heap of drugs gets taken out of a house.
Yeah, different kind of seizure.
Yeah.
Yeah.
And then the owner's like, had to get that one in there. That was a good one, wasn't it?
Yeah, it was pretty good.
Double
Pretty good.
word.
Yeah.
That's what you're paying the big bucks for here, folks. Well, you're not paying anything. But no, they're paying with their time and their attention.
5 stars.
Just 5 stars.
Is it stars?
5 stars on Spotify.
Okay.
Good man. And a follow would be great. Trying to get up to 200. I'm at 182 now, so it'd be great if you could, guys. And I'm at 180 YouTube subscribers.
Okay.
Yeah. So we're trying to climb. We're trying to get up there, and thank you so much for coming on.
Oh,
today,
it's a great time, Dan. Pleasure.
It's been so much learning. My head is like
fried.
It's just like every connection is just going, and I'm like trying to take it all in. It's just amazing. The knowledge that you have is great, and you can tell that you've done a lot of reading and learning, and that you're passionate about your job.
Oh, thank you. Yeah.
So it's really cool to meet someone like that.
Well, it's the same with any job. I mean, you're an electrician trained, if I can bring that up.
I'm trying to be a comedian.
Yeah, I know. Sorry, that too, obviously. Yeah. But it's like I find other jobs interesting. It's just like
electrician is it definitely made me think of. I know it's like I said earlier. I was trying to. I didn't even try to do it. Just the connection between the neurology and an electrical circuit.
Oh, it's all
the fuse board is the brain,
yeah,
and then the cables go out and make everything work.
Yeah.
And if a cable gets damaged, then the light stops working.
Yeah, it's very similar. Very similar. You're sure that is all electricity. The nerves are all electricity.
Yeah.
Yeah.
It's the same thing, isn't it?
Yeah.
So we're just houses covered in skin.
Yes, we're houses covered in skin.
Ed Gein was onto something.
Yeah, he was. Yeah.
That's a nice way to finish, isn't it?
It's a good way to finish.
Yeah. It's been lovely having you, Shane. Thanks so much. Get you back
pleasure.
on again. I'm delighted to have a resident neurologist now.
Yeah, anytime.
Welcome.
I had a lot of fun. Thanks a lot for inviting me.
No bother at all.
5 stars, everybody.
Yeah, exactly. Thank you very much, guys, for watching and listening. I hope you enjoyed this episode, and I will see you again on the next one. Thank you very much, and thanks again, Shane.
Of course.
Good
My
man.
pleasure.
Cheers. Excellent.